Today, I would like to present or talk to you about a common problem which is increasing day by day because of our lifestyle, that is gastroesophageal reflux disease and hiatus hernia. Good afternoon. So I've had quite a bit of experience in treating these patients from an early time. For the last 20 years, I've been operating on people with reflux disease and hiatus hernia. And I can see that of late that these things have been increasing considerably, causing a lot of problems to patients and also to the family members, because very often these patients present with chest pain and land up in the cardiology department. And then they're evaluated and told that what they're having is a reflux disease, and they're referred to somebody like me. Next. So by definition, what is gastroesophageal reflux disease? It is a digestive disorder that affects the ring of muscle which exists between the food pipe and the stomach. The food pipe is called as the esophagus, and the junction between the food pipe and the stomach, there's a ring of muscle which is called as the lower esophageal sphincter. That sphincter is always tightly closed, irrespective of the condition. The body regulates it in such a way that when we eat food, then the sphincter loosens and the food passes into the stomach, and immediately the sphincter closes the junction between the esophagus and stomach. This prevents the gastric contents, that is the stomach contents, coming up into the esophagus when the stomach moves, or because stomach is like a cement mixer where the food is churned nicely before it is let down into the small intestine. In that point of time, if there is a defect in the lower esophageal sphincter, then these people tend to have what we call as reflux disease, because everybody has acid in their stomach, and that acid refluxes into the esophagus and causes complications and also issues like even up to the stage of malignancy. Next. And then, as a progression of reflux disease, sometimes or insidiously, that is by itself, people can present with a hiatus hernia. What is a hiatus hernia? Hiatus hernia is a bulging of the stomach into the chest through an opening in the diaphragm. The diaphragm is a shelf of muscle which lies between the chest and the abdomen. So this diaphragm develops when the baby is in the mother's womb, and it separates the food, the intestinal organs, the kidneys, and all these from the chest, which contains the food pipe, the lungs, and the heart. So when there is a defect in the opening through which the food pipe comes, which becomes loose, then the stomach tends to move up into the chest. This happens very often because whenever we breathe, we know that the diaphragm goes down. When the diaphragm goes down, then there is a negative pressure inside the chest, and the air comes into the lungs. But when there is a negative pressure inside the chest with a patient for whom there is a loss of tone in the lower esophageal sphincter, then what happens is the stomach is pulled up into the chest every time a person breathes. Next. So this is the diaphragm as we see from below. It has basically three openings. One is where the blood vessel, the main blood vessel from the heart comes, which is lying on the spine that you can see. And then another one through which the blood vessel from the lower part of the body goes into the heart. And the third opening, which is in an oblique fashion that you can see in the middle, is through which the food pipe comes. So that is the area, if it is defective, will lead to a reflux disease or a hiatus hernia. Next. So it is very important to concentrate on the sphincter area or the lower part of the esophagus and the upper part of the stomach. As you can see in blue lines, that is the muscle, that is, or the phrenoesophageal ligament that we call it. It has branches which extend all round up to the esophagus and down into the stomach also. So whenever the diaphragm moves down, the lower fibers contract and the upper fibers relax. And at the same time, when the diaphragm goes up, the lower fibers relax and the upper fibers contract. So as a result of which, what happens is that the movement of the diaphragm does not cause movement of the esophagus. But when this system is damaged, then what happens is that because of the negative pressure inside the chest, the stomach gets pulled up into the chest. So you should keep in mind that the phrenoesophageal ligament is the one which gets damaged and which is responsible for maintaining the immobility of the esophagus when the diaphragm moves. Next. So as you can see here in this picture, you can see that the diaphragm can be up or down and the esophagus will not move. It is only the upper fibers which move or the lower fibers which contract. So in either of them, it is the diaphragm which is moving and based on the muscle fibers of the phrenoesophageal ligament. But the stomach and the esophagus do not move. But in a hiatus hernia, these phrenoesophageal ligament fibers are the ones which are damaged, as a result of which the stomach gets pulled up into the chest. Next. So, as you can see, what I've told you in the beginning, that the food and the acid in the stomach normally are not allowed to come into the esophagus. But when you have a reflux disease, you have the acid or the food coming into the esophagus, which causes the symptoms of reflux disease, which can vary from a chest pain to a symptom of regurgitation, that is, the food taken in comes out like a vomit. Next. So you can see the progression of the disease from a normal ring to the lack of a ring, where there is reflux of the food contents from the stomach into the esophagus, and 3, there is a movement of the stomach into the chest. So the third picture which you're seeing on the right is the one which shows the hiatus hernia formation which happens, and part of the stomach lies in the chest. Next. So the natural history of reflux disease is patients will have symptoms. We usually have different hypotheses for these things. This is more of a medical knowledge, but for a patient point of view, you should understand that initially patients will have symptoms where you will have probably a normal esophagus to look at, because the body has a phenomenal capacity to heal itself. But over time, what happens is the reflux of the acid causes damage to the lower end of esophagus, and they develop narrowing, which is called as a peptic stricture. So erosive esophagitis, which becomes very painful, sometimes even bleeds, and then it progresses on to a condition called as Barrett's esophagus, which is a premalignant condition. That is, most of the people who develop malignancy in this area have a progression from reflux disease to Barrett's esophagus to cancer of the lower end of esophagus. Next. So the common symptoms of reflux disease, what you should understand is you should have a burning sensation in the lower part of your chest or upper part of your abdomen. And then they complain of chest pain, and as a result of which, and there is difficulty in swallowing, because the acid, what happens is it refluxes into the esophagus, and the esophagus is not used to being exposed to the acid, as a result of which it goes into spasm and it tightly closes. When it tightly closes, you get a typical symptom of inability to swallow with chest pain and a burning pain. These 3 factors make patients rush to the hospital thinking it's a cardiac event. Very often, it is not. The reason is that the esophagus and the heart are supplied by the same nerve supply, Hence, the symptoms and the presentation will appear like a cardiac event. And then the other symptoms that happen with a continuous reflux disease is patients continue to have a sore taste in their mouth. They're continuously coughing because of the acid coming in, irritating your vocal cords, which we call as laryngitis. And then the change of voice might be there because they're all the time coughing and they have hoarseness. And their sensation of a swallowed food being stuck in the food pipe. That is, they always complain that I feel that the food is not going down into my stomach. I feel that it is being held up in the chest. Next. So, what are the risk factors for reflux disease? One, like I told you, it could be an insidious hiatus hernia. The other is obesity, which pushes up the diaphragm because of the high intra-abdominal pressure. Number three is pregnancy. So pregnancy also, because of the growth of the uterus, causes pushing up of the diaphragm, and a result of which there could be a damage to the phrenoesophageal ligaments, leading to a reflux disease. Gastroparesis or delayed emptying, which is very often seen in diabetic patients. See, diabetes causes gastroparesis, and uncontrolled diabetes or patients who have been negligent about their diabetes can develop gastroparesis, as a result of which the distended stomach causes a lack of tone in the muscles and also lack of tone in the phrenoesophageal ligament. Then of course, subsequently, the connective tissue disorders, which can cause damage to the ligaments by their nature itself. Next. So, this is the algorithm for the management of a reflux disease. What you should understand here is that it is medically treatable initially. So, if patients are having relief, we very often ask them to continue medication. But when patients keep coming back to us for recurrence of symptoms, then we investigate. And if it is positive for reflux disease, either they should consider anti-reflux surgery or a reflux inhibitor, or may have to plan for a definitive procedure like a laparoscopic procedure. And people who are negative for reflux disease require uh, treatment for functional dyspepsia. Next. So, what are the things that we should be doing to prevent the symptoms of reflux disease or GERD, which is called? So, most important thing is weight loss. So, in the weight loss, it should be related to your exercise and your diet. It's not just enough if you do only dieting or only exercise, because you have to have a consolidated approach for a weight loss regime which is sustainable and which prevents your reflux disease. Then the most important thing is to finish your meals with 2 to 3 hours before you go to bed, because that helps in preventing the stomach reflux, because in 3 hours usually the stomach empties by itself, and because the stomach is at rest, the reflux nature comes down drastically. And especially when you're lying down also, if you can have a 10 to 20 degrees tilt with the upper half of the body being up, then this will prevent the reflux from happening. Then using tobacco products, especially cigarette smoking, should be avoided, because what happens with cigarette smoking is it causes damage to the esophagus per se, causes gastritis, it stimulates acid secretion, which causes the chance of injury to the mucosa of the esophagus by reflux. Also, it decreases the tone of the muscles of the lower esophageal sphincter. And then you have trigger foods which should be avoided, like cheese or chocolate and coffee, too much of coffee and caffeine products, which should be avoided so that the reflux symptoms do not happen. Next. So, when we have to really treat these people who come repeatedly to us, then we advise these investigations for them, which is an endoscopy, a manometry, and an acid study, which is called as a pH study, and a CT scan only when they are planning for surgery. So I do all these investigations, initially only the endoscopy, and try to treat the patients medically. And then subsequently, when they have to undergo surgery, then the remaining investigations are done to confirm the disease and to see to the extent of the hiatus hernia that is there in these people. Next. So what could be the complications like I've suggested before? It could be esophageal ulceration. It could be a stricture, what we call as a peptic stricture, which requires dilatation very often in patients where there is narrowing of the lower end of the foot pipe. And then you have the Barrett's esophagus, like I told you before, which can lead to malignancy. One of the other things that is very important is patients having asthma. If patients have asthma, then, and especially the obese people, then you should look for a reason for why a patient is having asthma. And very often you'll end up finding that he has a reflux disease. As a result of reflux, what happens is the acid in the stomach comes all the way up into the foot pipe and into your throat and gets aspirated into the lungs, and it causes spasm of the lungs, which leads to features of asthma. Actually, it's a chemically induced asthma. So this is what people have to watch for, that always looking at asthma as a condition which is allergy should be avoided, and it should sometimes be looked at, especially in obese people, whether it could be reflux induced asthma. Next. Next. So when you see hiatus hernia, so there are 4 stages of hiatus hernia. One, where you have a small portion of the stomach coming up into the chest. Number 2, a larger portion of the stomach coming into the chest. 3, what we call as a paraesophageal hernia, whereas the stomach rotates on itself and part of the stomach comes all the way up in, whereas the junction, that is the lower esophageal sphincter and the stomach junction, continues to remain at a lower level. And number 4, or stage 4, is when it's the whole stomach, and not only the stomach, sometimes the large intestine, the spleen, and the small intestine, all of them are lying inside the chest of the patient. Next. So this is an endoscopic procedure which is advised in some people who are not amenable for surgical intervention. That is, they're either too old or high risk for anesthesia. So in these people, we can try an endoscopic procedure which creates a valve at the lower end of the esophagus, which is reasonably helpful along with other modulators of treatment. Next. So when we definitely have to do a surgery, it is doing a anti-reflux surgery, and it was pioneered by a lot of people. But what I do normally is a Nissen fundoplication or a Tope fundoplication. Nissen and Tope are the surgeons who pioneered the reflux surgery. So nowadays we do it laparoscopically only, and we use 5 ports, that is 5 openings. One of them will be a 1 centimeter opening, which you're seeing in the lower end, and all the remaining ones will be 5 mm each. Through them, we operate having a screen at the head of the patient, and looking at the screen, we operate on the patient. Next. So the steps of the procedure involve, see, the widening of the hiatus or the opening from between the chest and the abdomen is, when it is wide, you suture it and close it. At the same time, you should see that the foot pipe and the stomach are brought down and they're not lying inside the chest. Next. Then the part of the stomach is mobilized, and then it's wrapped around the lower end of the esophagus and sutured just like we suture a collar of a shirt. Just like a collar of a shirt, then the stomach is used to suture it. So this prevents the lower end of the esophagus migrating up into the chest. Next. Okay, this was a video which we are not supposed to present to you because of the graphic nature of the presentation. Next. This is an unusual condition which we are seeing nowadays, that is a reflux disease following bariatric surgery. So what happens is that in obese people, near the lower esophageal sphincter, you have a subhiatal fat ring. So when patients lose weight after bariatric surgery, this fat ring disappears or becomes very much less, as a result of which the stretched phrenoesophageal ligaments become very lax, which causes reflux disease. And for them, what I do is that I do a procedure called as a partial wrap, where part of the stomach or remnant of the stomach which is remaining is situated to the back of the esophagus, and then I do a Belzi Mark 4 repair, where part of the stomach which is lying in the front is sutured with interrupted sutures onto the lower end of the esophagus after closure of the hiatus. Next is a video again, which I could not show you, otherwise you would have understood this better. Next. Next. So then for the complex hernias, which are very wide, where we cannot approximate the defect, then we have to use a mesh in these situations. And we close the defect using a mesh. So I have a video actually for a type 4 hernia, but again, the same issue. As per regulation, we are not supposed to show the graphic contents to everybody. So anybody who's interested in knowing more about this disease can contact me. Next. Next. Thank you. Thank you for a patient hearing. Thank you. Right.